Hello everyone, I am Dr. Pushpa VT. I am consultant musculoskeletal radiologist from Ganga Hospital. Today I will be showing you how to do ultrasound of the wrist joint, which we commonly get requests from either rheumatologists or orthopedicians to look for various pathologies. So let's start with the ultrasound wrist. To begin with, I'll be showing what are the probes we'll be using and also a little bit of anatomy, and then we'll start with ultrasound probe.
We shall go through few anatomical pictures so that we can better understand the ultrasound images. On the dorsal aspect, we will be looking at extensor compartments of the wrist, which are 6 in number, distal radioulnar joint, radiocarpal and midcarpal joints, radial artery and nerve, selected midcarpal ligaments, which are nothing but scapholunate and lunotrachmitral ligaments. To study the extensor compartment of the wrist, we need to identify an important bony landmark on the dorsal aspect of the radius, which is nothing but listus tubercle. The tendons just radial to the listus tubercle is the second compartment tendons. However, if you go further laterally, that is further radially, you will see the first compartment tendons, which is abductor pollicis longus and extensor pollicis brevis. The second compartment tendons are extensor carpi radialis longus and brevis. The tendon, the single tendon which is just ulnar to the listus tubercle, is the third compartment tendon, which is extensor pollicis longus. The fourth compartment has extensor digitorum and extensor indicis. Fifth has extensor digiti quinti minimi, and the sixth compartment is seen within the ulnar group, which is nothing extensor carpi ulnaris tendon. Now all these tendons are held together by means of extensor retinaculum. You should remember this extensor retinaculum also thickens individually along each of these compartments to give a additional enforcement. So you should remember, and especially when it comes to ECU, you should make sure that you will evaluate both of these extensor retinaculum as well as the ECU tendon sheath separately to make sure there is no pathologies. One more important thing to remember in case of the dorsal wrist is that there is lot of crossing over of those tendons before they attach to the particular bone. So the first compartment tendons cross over the second compartment tendon before they go and attach to the thumb, about 4 cm proximal to the wrist joint. So that is the proximal intersection point. Whereas the third compartment tendon, that is the extensor pollicis longus, will cross over the second compartment tendon to attach to the thumb at the level of the wrist joint, which is the distal intersection point. So you should remember where the intersections happen, which can be a site of pathology in case of repetitive injuries. Just below the fourth compartment, you will be able to see the dorsal radioulnar joint. When you go further distally from the lunate tubercle, you will be able to identify scaphoid, lunate and the triquetrum and the respective scapholunate and lunotriquetral ligaments and joint. In the sagittal plane, you will be able to identify the radius, lunate and capitate based on their configuration. Especially the capitate will have peanut-like appearance, and the joint spaces, that are midcarpal and radiocarpal joints, can be evaluated in the sagittal plane. The radial artery and the nerve are in close relation with the first compartment tendon, which we will be able to look in ultrasound when we are demonstrating the same. Coming to the volar aspect, again here we have two tunnels. One is carpal tunnel, another one is Guyon's canal. We have the flexor retinaculum here, like how we had extensor retinaculum on the extensor aspect. We have flexor retinaculum on the volar side, and we will study the contents within the flexor retinaculum, that is carpal tunnel. To identify the flexor retinaculum, again you need to look for a bony landmark, which is pisiform and the tubercle of the scaphoid bone, and bridging these two structures is your flexor retinaculum. and the flexor retinaculum will be holding 9 tendons of flexor digitorum and superficialis as well as flexor pollicis longus tendons. So it has 9 tendons within it and one nerve which is nothing but median nerve. So median nerve is quite superficial and it is just underneath the flexor retinaculum. As you trace distally, you will start looking at the distal carpal tunnel, which is bordered by hook of the hamate and trapezium, and again the median nerve will be seen just underneath the flexor retinaculum. One more structure which we have to give close attention is to the Guyon's canal. You can see the contents of the Guyon's canal, which is nothing but ulnar artery and ulnar nerve, are seen just on the inner surface of the pisiform bone. And as you go further distally, you can see that the contents of Guyon's canal are seen lateral to the hook of the hamate. Here is the place where ulnar nerve divides into superficial and deeper branches. The deep branch is actually a motor branch and the superficial branch travels along the ulnar artery to be a sensory nerve root. Now the ultrasound can be done using two types of probe. One is hockey stick probe and another one is a high frequency linear probe. For the dorsal aspect, since the structures are quite superficial, I prefer to use hockey stick probe, whereas when I am doing the volar aspect, the structures are slightly deeper, I will prefer a linear high frequency probe. So you can choose accordingly what you feel comfortable. Now the patient can be either in lying down position or sitting position. I prefer to do it in lying down position since the patient can comfortably place the hand by the side of him or her, and also if I have to do some dynamic maneuver, it will be easier if the patient is in lying down position. So I prefer lying down position, but people do it in sitting position as well. Placing one rolled towel or a jelly bottle just at the level, just below the wrist joint, will help you to perform some dynamic maneuvers like flexion extension of the finger or medial or lateral deviation of the wrist joint can be easily done if there is a rolled towel just underneath the wrist joint. So let's begin with the ultrasound now. Okay, let's begin with the ultrasound of the wrist. You can see the patient is nicely, comfortably lying on the bed and arm is on the sides of her. And we will first evaluate the dorsal aspect of the wrist. Here we'll be seeing all the 6 compartments of the wrist joint. We'll be also looking at the dorsal radial joint as well as some important joints like scapholunate joint and lunotriquetral joints and the ligaments. And also we'll be evaluating the radial nerve. The first thing which we have to do when evaluating the dorsal aspect of the wrist joint is to look for an important landmark, which is nothing but Lister's tubercle. To do so, I'll place the probe little on the radial side of the wrist joint where you'll be able to see the Lister's tubercle. As I already discussed, the structures, that is the tendons which is just radial to the Lister's tubercle, is the second compartment tendon. In order to see the first compartment tendon, I'll just move the arm of the patient to the lateral side and also ask the thumb will be moved towards the ceiling. So like that, on the lateral aspect of the wrist, you'll be able to see the first compartment tendon over the radius. You can see the nice retinaculum of the first extensor compartment, and there are 2 tendon slips within the first extensor compartment, which are abductor pollicis longus and extensor pollicis brevis. The most important thing to remember in the first compartment is there can be a thick septation in between these 2 tendons, which has to be identified and reported, because if at all there is tenosynovitis, it is very important to excise this septation between these 2 tendons for the complete cure. Again, when you are giving injection, it is very important to inject both tendons separately, because otherwise the treatment can be incomplete.
Thing to remember in the first compartment is that abductor pollicis longus tendon can have multiple tendon slips which will look like a lotus stem. So that is very important to remember, and you should not think it is a tendinosis or some pathology. The most important things around the first compartment is the radial nerve and the radial artery. So here you can see the radial nerve crossing over the superficial aspect of the tendons. So you can see the nice movement of the radial nerve above the first compartment tendons, and also you can see the radial artery which is on the deeper aspect of the first compartment tendons. We have done with the first compartment now. For the second compartment, again you can see the wrist is brought back to its previous position, and you identify the listus tubercle, and the structures which is just radial to the listus tubercle is your second compartment, which has two tendons. One is the extensor carpi radialis longus and the second one is extensor carpi radialis brevis. So these tendons should be evaluated at the level of the wrist joint, and also you have to trace it around 4 centimeters proximally from the wrist joint to see the crossing over of the first compartment tendon over the second compartment tendons. This can be a source of irritation and formation of the bursitis, especially in case of some sporting injuries. So it is very important to trace these tendons just proximal about 4 centimeters from the wrist joint to see for the proximal intersection syndrome. So this is again I am illustrating the first tendon sheets crossing over the second tendon sheets before they come towards the wrist joint. Distally, these two tendons can be traced up to their insertion to the bases of second and third metacarpal bones. Coming to the third compartment, it has only one single tendon, that is extensor pollicis longus, which is seen just ulnar to the listus tubercle. So that is the tendon there, that is ulnar to the listus tubercle, and you can see it crosses over the second compartment tendon, that is the distal intersection point. So this third compartment tendon is crossing over the second compartment tendon towards, and it runs towards the thumb and attaches to the thumb bone. So that is the importance of the third compartment tendon, where it is crossing over the second compartment tendon, where there is possibility of distal intersection syndrome in some sporting injuries or repetitive occupational hazard. One more important thing to remember is this is the most important tendon which can get injured in case of undisplaced radial fractures, possibly because of ischemic events. Now let's start with the fourth compartment. You can see the fourth compartment has multiple tendons. So these are extensor digitorum tendon and extensor indicis. As you know, the extensor retinaculum is thickest at this region, and also the tendon sheath is thickest at this region, mainly because it is having multiple tendons. It is important to remember this because it can be easily confused with tenosynovitis, just because the tendon sheath is looking little thicker, the retinaculum is looking little thicker. So it is important to remember it can be normally thicker. So in case of doubt, you have to compare with the other hand. So another important thing to identify when you are evaluating the fourth compartment is the posterior interosseous nerve, which can be in and around just posterior to the fourth compartment. So it is very easily identifiable at this level. Moving to the fifth compartment, you have only single tendon here, which is nothing but extensor digiti minimi, and you can see it runs towards the little finger to gain the attachment. So that is your extensor digiti minimi tendon, which is the fifth compartment tendon. Moving to the sixth compartment, you have to slightly move the arm towards the ulnar side and try to identify the ulnar groove. So that's the ulnar groove, and you can identify the extensor carpi ulnaris, which is the sixth compartment tendon. you should remember that the extensor carpi ulnaris has a separate tendon sheath or a retinaculum which holds it to the ulnar bone, and also has an extra retinaculum, that is the common extensor retinacular sheath. So that is very important. In case of tenosynovitis or in case of disruption, especially in tennis player and shuttle badminton player, there can be injury to the retinaculum of the extensor carpi ulnaris, which will involve both its retinaculum as well as the common extensor retinaculum. Now we have seen all the tendons, all the 6 extensor compartments of the dorsal wrist joint. We will be looking at some important joints. To do so, again we'll have to go back to our important bony landmark, that is the listus tubercle. And as you slide more distally, you will start seeing the scapholunate ligament. So that is the scaphoid and the lunate. You can see a triangular scapholunate ligament very nicely over there. So there is no thickening or there is no fluid accumulation within the scapholunate ligament of the joint space. To do a dynamic examination of this joint, you can just give a slight ulnar deviation to the wrist joint, and you can see there is nice stretching of the ligament and also mild widening of the joint. So this is a dynamic examination you can do to evaluate the scapholunate ligament in a better manner. As you go towards more ulnar side, you can also see one more triangular ligament there, that is the lunotriquetral ligament. So these are the two important ligaments you can identify in the dorsal aspect of the wrist joint. Another important joint to evaluate is the distal radioulnar joint on the dorsal aspect, which will be just underneath the 4th and 5th compartment of the wrist joint. So that is your dorsal distal radioulnar joint. You can see it is having a nice synovium there where there is no effusion. So in case of rheumatoid arthritis or some sort of joint infection, you will definitely able to see some amount of fluid collection in this joint recess. So in the sagittal plane also we'll be able to see the radiocarpal and midcarpal joint. Here you can see I have placed the probe in the mid-sagittal plane, and you can identify the radius, the lunate and the capitate. Capitate has a peanut-like appearance with a shell, and if there is any joint effusion and synovial thickening, it will be easily identified. So only if there is synovial thickening, which it is not very important finding unless it shows some vascularity. If there is synovial thickening along with vascularity, that it indicates definite pathology. Let's start with the volar aspect now. As I already described, we will be looking at the few important tendons, that is flexor tendons, median nerve, ulnar nerve and the retinaculum. So let's begin with the important bony landmark at the level of the wrist joint. You can see two important bony landmark, which is pisiform bone and the scaphoid tubercle. Bridging these two bones, you can see a thick retinaculum, which is nothing but the flexor retinaculum, which is holding all the carpal tunnel contents. So what are the carpal tunnel contents? These are nothing but flexor digitorum and superficialis tendon, and one more tendon, that is flexor pollicis longus tendon, and we also see the median nerve. And how to differentiate the median nerve from the rest of the tendons? So for that the anisotropy is very helpful. So as I toggle my probe, you can see the echogenicity of the tendons is completely changing, whereas the median nerve is similar in appearance in whatever the probe position it is. So you can see it is maintaining its honeycomb appearance, and it is just beneath the flexor retinaculum. So that is your median nerve, and rest of the tendons are flexor tendon. Other than digitorum and superficialis flexor tendon, there is one more tendon, which is flexor pollicis longus tendon, which is inside the carpal tunnel itself. So you can identify by doing a toggling movement of the probe as well as by wiggling the thumb. So you can actually see the movement of the flexor pollicis longus tendon within the carpal tunnel there. Now let's see the median nerve in further detail. So to look for the median nerve, as I already told, it is just underneath the flexor retinaculum, and it has a nice honeycomb appearance. We should make sure that it is not having any thickening, or there is no compression on the median nerve, and there is no distortion of the median nerve as well. And coming to the size of the median nerve, it should not be more, the area of the median nerve should not be more than 12 millimeter square. If it is more than 12 millimeter square, it is definitely abnormal. Another way to look at the size of the median nerve to tell whether it is compressed or whether it is involved with the carpal tunnel syndrome is to look at the size at the level of the wrist joint, that is at the level of pisiform and the scaphoid tubercle, and then go little proximally where you start seeing the pronator quadratus. So at this level you can measure the median nerve, and if the size of the median nerve has a difference of more than 2 millimeter square, then that is definitely abnormal. So these are the things you will see within the carpal tunnel at the level of the pisiform bone. Now I am tracing the median nerve further down, that is further distally. Here again you look for another bony landmark, that is the hook of the hamate. So you are looking at the hook of the hamate and also the trapezoid bone. Here you can see the retinaculum, that is distal flexor retinaculum, is further thickened, and again it is holding all the flexor tendons. So again you can see the median nerve and the flexor tendon and the hook of the hamate and the trapezium and the thickened flexor retinaculum in the distal aspect. So you can further trace them distally, where you can see the median nerve divides into branches and supplies various fingers, and the flexor tendons also dividing and supplying each of the fingers. Here you can see they are accompanied by the lumbrical muscles, which main important function is to flex the metacarpal joint. So these are the flexor tendons and the lumbricals with the branches of the artery as well as the median nerve. Once we finish the carpal tunnel, we will go to the Guyon's canal. Here again I am looking at the pisiform bone. Just radial to pisiform bone you see two distinct structures, that is ulnar artery and ulnar nerve overlying the flexor retinaculum. So that triangular structure is your Guyon's canal, and you can see the ulnar artery is more radial to the ulnar nerve. So I am tracing the ulnar nerve, and as we go towards the hook of hamate, you can see the ulnar nerve and the artery are going lateral to the hook of the hamate, and ulnar nerve is actually dividing into two, into the sensory as well as the motor nerve. The sensory nerve actually follows the ulnar artery, whereas the deep fiber is going towards the hypothenar eminence to supply the muscles. So that's about the Guyon's canal. Now let's go back to the wrist joint level, where we will see the rest of the structures outside the carpal tunnel. At the level of the scaphoid tubercle, you can see a tendon which is nothing but flexor carpi radialis. At the level of the median nerve and above the retinaculum, you see a structure, that is palmaris longus tendon, and towards the pisiform bone you can see that is the flexor carpi ulnaris tendon. So these are the rest of the tendons you can see nicely when outside the carpal tunnel and Guyon's canal. So by this we end the examination of the wrist joint, both in the dorsal as well as volar aspect. Thank you very much for patience listening.